All right. Thank you, Dhruv. I want to thank him also for making my job so interesting. I've been coming to the hospital, Beth Israel, right across the street here for more than 35 years, and it's amazing to me that I can meet somebody like that makes my job so much more interesting, and he's really been a joy to work with over the years. And I also want to thank Kathy for inviting me to the symposium. She said that she mentioned there's a lot of different imaging with lymphedema, and she wanted me to go through the different imaging procedures that we do, just so you guys can kind of understand why we do the imaging that we do. And keep in mind that it's quite variable. Not all places do these imaging techniques. We're lucky that we are able to do most of these here at our institution, both because Drew has pushed for it, but also people like Leo Tsai, who's a radiologist who's been instrumental in getting a lot of the other radiology involved. I'm a nuclear medicine specialist. I trained in internal medicine and then didn't go into radiology. I went straight into nuclear medicine from internal medicine a number of years ago. And so I obviously have a warm spot for lymphoscintigraphy and for the nuclear imaging, but I'm going to talk about all the different types of imaging that we do. Of imaging modalities, there's ICG, and Dhruv just showed a number of pictures of ICG. And this provides, the advantage of ICG, it provides this detailed structural information about the superficial lymphatics. Then we also have MRI, and we do MRI on a lot of our patients. And the advantage of MRI is that it provides this anatomic information about tissue composition. So you can look at a limb with MRI and tell just how much is fat, how much is fluid, and the distribution of the fat. And you can show lymphatic channels with MRI, but it's not easy to do. We have Leo Tsai is one of the best MRI specialists in the country, and he has a little trouble with it sometimes. But the technology is developing, and I suspect that it won't be before too long that MRI lymphangiography will become routine. We also do a high-frequency ultrasound, and this is a specialized imaging procedure when we're more interested in looking at fine detailed anatomy when there's a consideration for lymphovenous bypass. And then, of course, there's nuclear medicine, and the advantage of nuclear medicine is we provide functional information. All these other studies are mostly related to anatomy, but nuclear medicine shows how things flow on their own. And we'll talk about a number of these things. So ICG, this is the stuff, indocyanine in green. It's a little vial. You pull it up in a little tuberculin syringe and inject it intradermally there. And it's important that you get it in the dermis. You don't want to go subdermal because you got all this rich lymphatic channels in the dermis, and if you go subdermal, it makes it less likely that the dye is going to be taken up. So there's a little technique involved with doing the injection. Then once you inject the dye, it is taken up in those lymphatics and then ends up in the channels, as Dhruv showed. And what happens is there's a special light source, a laser diode, that shines a particular frequency of light on the dye, and then the dye fluoresces. It turns this green color and gives off light, and that's picked up by these cameras that have filters that filter out the specific wavelengths they want to look at, and so you get to see these this dye in the arm. And here is a real-time image of how we do the imaging, and you can switch between green and white light, and then you can see some places where there is some skin markings that they do, and then you can turn off the camera and see the anatomy where you are, and then go back down and follow these different the different channels that you see. And you can see here there's some markings on the skin that you can see, and you can see some linear channels here. And then you can turn the wrist over and look again, cruise up and down. And a lot of times while this is going on, the operator is massaging the arm and trying to see where they can get this dye to go, and they're kind of manipulating and doing their best to see where the dye is going. And then you end up with a picture that shows, you know, the lymphatics on the arms, and you can draw the channels on the skin there to get an idea if that's helpful for you. And the ICG findings are categorized into a number of different categories here. First, you have linear channels, and if you've got these nice straight channels, the dye flows nice and smoothly and evenly through these channels, then great, that's normal. But every now and then, if there's a little bit of obstruction, you get what we call a splash pattern, where it kind of spreads out a little bit. You still have some linearity, but it's spreading out the dye is spreading out a little bit in the skin. And then next on the line is a stardust pattern, and you get these little spots where the dye just can't get out of there. It just gets stuck and is looking for channels to get out of there. And then the worst pattern is this diffuse pattern where we see just a big blob of activity of that channel there. And so to interpret all these different things, here I've got some still views here, linear channels, and here's this stardust pattern where it's not as well organized, not quite as linear. And then this is a nice helpful finding when you have this nice linear channel and then it just goes into this stardust pattern. And we can hypothesize that there's an obstruction at that level. And that gets the surgeons very interested in looking in that region to maybe bypass this channel, hook this into a vein, and to bypass this area of obstruction here. So the advantages of ICG is it shows the superficial lymphatics in detail, and it can be helpful for localizing sites of obstruction. It doesn't have any ionizing radiation associated with it, and the equipment is relatively inexpensive. I mean, it's not cheap, but it's relatively inexpensive when you compare it to MRI and nuclear medicine and some of those other things. The disadvantage is it requires skill. The operators that do these, the therapists that do these, have to know the lymphatic anatomy. They have to know how to do the injections correctly. They have to know how to massage to get it to move. And they have to be able to photograph. And then they have to be able to categorize, because they report to us and they say there's a stardust diffuse pattern here, there's a linear pattern here, and that's very important information for figuring out what's going on with this particular patient. The disadvantage is it's not physiological. They're pushing this stuff through the channels. It might not go there anyway, but they're really pushing it through, and so not quite like nuclear medicine. And then also it's time intensive. It takes a lot of time to get that the dye to move sometimes. Take all those pictures, catalog all that, and figure out how you're gonna report the study. Next, we have MRI, magnetic resonance imaging, and magnetic resonance imaging is great stuff. Other than the fact that it may replace my job, MRI is advancing rapidly, especially when you have such an active group as we have at our institution, and we're finding new things all the time with MRI. Now, with MRI, of course, you got this tube that you got to get into. That's a very narrow opening. And for any of you that have had an MRI, I mean, that tube is right here in your face. And if you have any problems with claustrophobia at all, it's a problem. There are ways to help alleviate some of that. There are some dedicated machines just for the limb. You don't have the problem with the claustrophobia. And also there are different coils that we use to help us see the lymphatic anatomy a little better. And the way MRI works is that we've got all these protons in our body. It's part of, most of our bodies our cells are made up of water, and all these hydrogen atoms, these protons are in there, and they have spins, and they're spinning around. And when you spin, you have this magnetic dipole, and so one spinning and pointing this way, one spinning and pointing this way. And then with the MRI, you put them in this very strong magnetic field, and you line up all those protons in one direction. And then you cancel that field, and the protons all relax and go back to the way they wanted. And then they give off a signal. They get off a magnetic signal that you can pick up as they're realigning themselves, okay? Now, this is what has been explained to all of us. However, I think it's magic, and so that's what I tell the patients. And the nice thing about MRI is you can, by lining up these protons and flopping them back and forth, you can look at different types of tissue in the body. And here's a patient, a couple legs here. And you can see this leg is more swollen, larger cross-section, and all this white stuff is fluid. And so we can look in the interstitial, into the legs there and say, you know, get an idea of how much fluid that patient has. Whereas the same patient, you change the sequencing and the way you image with the MRI, and you can look at fat instead. And now you can see all the fat, and you can look at the difference in amount of fat and fluid between these two legs. And that's hugely helpful for the therapist to say, okay, this patient still has too much fluid in their legs. They need more compression. They need more manipulation and massage and maybe a pump or something like that. And once we get all the fluid out of there, then we can address the fat and that kind of thing. So that's very helpful to us. And here's lymphangiography, and it's really an amazing way of looking at the lymphatic system. But like I say, technically it's kind of difficult to do right now. For reasons that I've talked to Leo about a little bit, but we're working on this, and like I say, I may be out of a job pretty soon. So the advantage of MRI is it shows tissue composition. You can see how much fat is there, how much fluid is there. That really helps management. It's a great anatomic detail, even to the point that you can see lymphatics on lymphangiography, and there's no radiation exposure with MRI. The disadvantage is that it's very expensive. It's not physiologic. Again, you're just looking at anatomy. And then the technology is changing very rapidly. You know, I talked to Leo about a particular imaging sequence or a particular coil or something, and then a couple months later, I'll be asking him, oh, we don't use those anymore. We got a better thing now. And I mean, it's great for patients. I think that the future is very bright with MRI, but it's tough for me to keep up with it. And then it requires very highly skilled operators. You know, Leo's no joke. He's very accomplished, and he's doing problem solving as he goes from patient to patient, and working with the technologist, showing him how what sequences to use, and I'm really in admiration of his skill. And then, of course, the equipment is very expensive and bulky. You can't just take this around very easily, and so it's not as portable as something like the like ICG is. And then we have high-frequency ultrasound. I just have one slide on high-frequency ultrasound, but this is the regular old ultrasound. Very hard to see the anatomy here. And here with high-frequency ultrasound, you get much nicer view of the anatomy. And we particularly use this when we have a patient that we're considering for lymphovenous bypass. And Leo will come in here with the high-frequency ultrasound and find a lymphatic channel, find it close to a vein, and let Dhruv know, yeah, I think you can hook these two up together. And instead of Dhruv just sort of probing around there trying to find things after they open somebody up, we can localize the site of surgery much better. So the advantage of high-frequency ultrasound, no radiation, exquisite anatomic detail. The equipment is fairly portable, and they're fuzzy images. They make my images look good. So I like that about the ultrasound. The disadvantage is you got to know what you're looking for. Again, Leo has been doing this, and we have other radiologists that can do this. But they got to know what they're looking for, how big a channel is to look, and there's a lot of moving around. It does take a lot of time to find these sites. You know, if I can't find it at the ankle, I'm moving up the leg and trying to find it up there, then moving up a little higher. You're looking all over, and sometimes you can't find the lymphatics very well, especially if somebody's got lymphedema, a big swollen leg. It's very hard to find a patent lymphatic channel, and so it can be very time intensive as well. So now let's talk about lymphoscintigraphy. This is what I do, and we do the same intradermal injection that you do with ICG, only we use a colloid particle. And colloid is like just a little particulate. It's sulfur colloid. It's a tiny little thing. Some of our people say just little pieces of dirt. You know, obviously it's not dirt, but it's these kind of inert particles. And then we use gamma cameras to image how this tracer is moving at delayed intervals. And sulfur colloid is just a little solution you mix up here, and this is the intradermal injection. And it's important. This is one of the techniques that's a little difficult to train the residents in that you gotta. It's a thin little needle, a little tuberculin needle. It's got to be almost tangential to the skin surface, and you just barely get the bevel of the needle under the skin. If you go very far, you're going to get into the subdermis, so you just barely get that bevel under the skin. And then when you inject, you raise this little wheel. And like most of you have seen with the TB skin test, when you have a TB skin test. If you raise this nice little wheel, then you know you're intradermal and you're where you want to be. And then this is our equipment. Again, it's not a little portable thing. It's a big, bulky piece of equipment. And this is a SPECT CT machine. And so SPECT is single photon emission computed tomography. And the single photon part of it relates to what's given off by the tracer. The sulfur colloid gives off a single photon, and emission computed tomography is just like the CT, or the regular CT. We have these detectors here. Here's a detector, and here's another one down here. And these rotate around the patient, and we can get tomographic views from all different areas. And then you've also got the CT portion of it, which is this large ring and back, and that gathers a CT. So the patient will go through the CT, get a CT on this table, and then without moving, we then do the SPECT imaging to see where the tracer is. And then we can fuse those two data sets and see exactly where that lymphatic activity is. And this is another view of the equipment where you can see a little better what a patient looks like when they're in the machine there. And these are the heads for acquiring the lymphoscintigraphic information, and then the CT is the big machine behind there. And so I talked about some of the advantages of the others is there's no radiation exposure. And I'm always a little anxious about saying that because in general, I find that people are a lot more frightened of radiation than they deserve to be frightened of it. I don't think it should be flung around willy-nilly. I mean, I had to spend a lot of training, and I get paid the big bucks because I went through all this training to learn how to handle radioactive materials. And I don't want it, anybody can do it now. And because I think that if anybody does it, then it does get abused quite a bit. But For the lymphoscintigraphy that we do, it's one of the lowest dose studies that we do. We inject a very small amount of tracer, and it's like background doses. And we've talked to our volunteers about, I talked to the volunteers about that, and it's kind of the amount of radiation exposure you get from lymphoscintigraphy is kind of like the difference of living in Boston or going to live in Denver for a year. You get twice the background radiation exposure in Denver, Colorado that you do here in Boston. But nobody says, oh, don't go to Denver because you're going to, you know, people are there very, very healthy and happy. And so it's a very low dose. You do get an additional dose from the CT, but again, it's a low dose CT and it's just done at a localized area to see things. Like I say, you know, I don't want to trivialize it too much, but I think that if you've got a patient that has lymphedema you know, that should be your main concern, and not which test should I do, but if you're trying to decide which test to do, pick the test that gives you the best diagnostic information. Don't worry that much about the radiation exposure when you're dealing with these patients. A lot of times, you got to realize that having them drive in an hour to the hospital or 45 minutes to the hospital is probably more risky than the radiation exposure we show them. And so the other nice thing is we do images acquired at different time intervals, and we get to monitor the movement of the tracer on its own. And we found that exercising, most places do a little exercise. For lower extremity lymphedema, we have the patients get up and walk around a little bit between imaging sessions. And for upper extremity, we give them a ball to squeeze before we inject them. We have them do arm movements, and then after we inject them, we have them do it again. We have this specific protocol that that the technologists do to get the patient's lymph flowing a little better. And then we like SPECT CT for it really helps us with the localization of where the tracer is going. And with lymphoscintigraphy, we can see a number of things. We can see channels, we can see lymph nodes, and we can see dermal backflow. Dermal backflow is, by some people consider dermal backflow as a sign you have to have if the patient's going to have lymphedema, if you're going to diagnose that patient with lymphedema. Channels we're not as good at as we'd like to be. You know, we've got our colleagues from Australia here. They've got a better tracer available there. They have antimony sulfide colloid, which gets taken up in the lymphatics a little more quickly than sulfur colloid does. Sulfur colloid's a little bit of a larger particle, but the FDA won't let us have antimony sulfide colloid here. And in this country, sulfur colloid's the standard, so you know we put up with it. But if they did make antimony sulfide colloid available to us, we would certainly use that here. And so we don't always see channels. We do see nodes frequently. And then, like I say, if we see dermal backflow, that's one of the diagnostic signs of lymphedema that we use. And this is a typical picture we get with lymphoscintigraphy. Here's a patient. We do 30-minute images here, and then we do 2-hour images over on the right side of the screen there. And the 30-minute images show you nice channels from the feet going up to the inguinal area here on the left. On the right side, you get a little bit of blush here, maybe a little dermal backflow here. The channels are moving up there. But then at 2 hours, we see now you're all dermal backflow. This diffuse activity here in the thigh and in the upper lower leg, that's all dermal backflow. You lose the channels at that point, and we really don't see much of anything as far as nodes. There might be a little bit one here, but certainly nothing near what you see on the asymptomatic side, the left side over here. And so by looking at these findings, we can help show sometimes where the obstruction is and also the degree of obstruction that's there. And again, dermal backflow, how we think about that is, let's say one of these deeper channels gets obstructed. So where does the lymph go? If it can't go to the deeper channels, then it's got to go back up these. My little pointer is given out here, but it's got to go back up the other channels to get up back into the dermis, where you've got that big flat network of lymphatics. And so it leaks up into there and spreads out through the skin, and that's how we get our dermal backflow. And then we can also, as Drew showed earlier, some pictures, we can also look at the differences in distribution. This is 2 different patients. We can spin this around and look at the look at where these lymph nodes are, and then on the CT we can also point them out and see where they are, and we can help sometimes the angiographers know that they can stick a needle in this one lymph node, inject some contrast, and look to see what the lymphatics are from draining that node. And the other thing that Drew touched on that we are looking at for anatomic variations to try and decide who is predisposed to developing lymphedema before they have surgery. And what you're seeing here is 2 different normal volunteers. They're both young women that we're doing as part of our R01 study. They were both injected exactly the same in the hand and wrist, and this one has epitrochlear nodes, she's got humeral nodes on both sides, she's got lots of nodes in both axillae, and this one, she's got 2 nodes, maybe 3 nodes over here and 1 node over here. That's got to be a difference, and these are both normal volunteers. And then we can put that, and what we'll do for our R01 study is we inject in the wrist, we do images to see where the wrist drains to, and then we inject in over the cephalic vein. Drew talked about the SAPI pathway over the cephalic vein, and you can see, then I can go in and label, and I can say, okay, some of these nodes are being drained from just a wrist injection, some from cephalic injection, and some from both cephalic and wrist injection, and get an idea of mapping the nodes. So lymphoscintigraphy, the advantages are it's the most physiologic study. You get to see the tracer move. You get to see the deep lymphatics. You can see where those nodes are. Once that ICG goes deep, you lose track of it. And then also we can see the location of the draining nodes, which nodes in the axilla or in the epitrochlear or humeral drain which injection site. The disadvantages, like I say, radiation exposure, which I almost hesitate to put on this list for fear that people will overemphasize the dangers of that. But also, we don't have real reliable demonstration of channels, and our anatomic detail isn't great. We can see, especially with SPECT-CT, we can see things a lot better, but we don't have the detail that you have with MRI and ICG, and then also you may require the presence of nodes to show deeper channels. And that one patient that Drew talked about that I called him about on one weekend, it was a patient in our R01 study, and we are looking at patients that have had surgery and that have no lymphedema, and looking to see how much different their lymphatic anatomy is from patients, we got a lot of patients with lymphedema, but also from the normal patients we're doing. And this woman came in, no lymphedema at all. I injected her, and she had an epitrochlear node and a humeral node, and that was it. She had no other nodes showing up anywhere. And so they removed all her nodes from axilla, but she still didn't get lymphedema. And that just kind of underlined to me that for me to see where the tracer's going, I got to see lymph nodes. And so somehow she figured out how to bypass all those lymph nodes that they took out and get her lymph to her superior vena cava without going through any lymph nodes. And so we're finding some very interesting variations like that. So with that, I'm a little early, but if anybody has any questions about all those different imaging technologies.
So historically, the biggest complaint I hear from patients about lymphoscintigraphy is how painful the injection is. Can you speak to whether there's any advances in that and whether that continues to be an issue?
Yeah, that can be a problem, the pain at the injection site. And it's very interesting to me. I do a lot of injections for patients that are there for sentinel node imaging. They had recently breast cancer diagnosed. They're getting a sentinel node surgery to see which nodes drain around the tumor. And when I go in to see that patient, I can tell whether they're going to have pain with their injection just as I walk in the room. If they're holding onto the cart with white knuckles and they're crying or they're upset, as you certainly understand they would be, they don't want to be there, they're anxious, the injections are going to hurt them quite a bit. Whereas some other women that you go into, they're shooting the breeze or talking to, oh, hi, how you doing? And yeah, can we get this over with? Because I'm going to want to go horseback riding in the afternoon and, before I go for my surgery and that kind of thing. And you inject them and they're yakking away while you're injecting them. So not to say that the injections don't hurt. They do sting, but a lot of it is the way the patients are thinking about it ahead of time. We found that with sulfur colloid, the tracer that we inject, that it was fairly acidic when we were getting it from the pharmacy. It had a pH of like 6.2 or so. And so we buffered it up to 7, pH of around 7, and we had a lot fewer complaints about the pain. Then there's another tracer that was recently released, well, not recently, in the last several years, called tilmanocept. And it's not a particulate, it's a little molecule that binds to the CD206 receptors on the lymphocytes. And that was advertised as being a lot less painful. And we did notice that women seem to have less of a problem with the injections with tilmanocept. But then I talked to the technologist there and I said, if you could inject sulfur colloid tilmanocept, which would you inject? And she said, we had one patient that came back for her second study, her second lymphoscintigram, and she just didn't want to have it. She said she had so much pain with her first injection, she was really reluctant. And for her first injection, we had used tilmanocept, and we had switched to sulfur colloid in the meantime, so we injected her sulfur colloid. She said, hey, that wasn't bad at all. So there are people that say, how about putting some topical anesthetic, like Emla cream? But some of the work that Dhruv has showed that the Emla cream can cause the lymphatic channels, the microchannels to contract and slow the movement of tracer. So it does bother me that it's painful, and I haven't figured out how to fix that yet. And certainly, if we can find something to fix that, we will. But most of them, yeah, I didn't like that, but they come back. With our volunteers, they come in on 2 different days, and we don't have anybody say, oh, I'm not coming back for the second day because that first day was so bad. So I think it's one of those things you get through, and these women are facing terrible surgeries and debulkings and all this other stuff, and hopefully the injection pain is sort of in the back of their mind, is not one of the worst things that's happened to them.
Thank thank you for your speech. It was great. I wanted to find out, are you picking out the type of diagnostic based on the stage of lymphedema?
So what kind of imaging we do based on, keep in mind that I see patients that they referred to me. And if you talk to Dhruv and Brett, most of the patients that come to them for lymphedema don't get any imaging. They either get sent to physical therapy, or they say, nah, you don't have lymphedema. You got something else. You got a cellulitis, or you got a venous problem, something like that. And so the referring physicians, Brett and Dhruv, decide what kind of imaging is helpful for them. Like I say, if they're considering lymphovenous bypass, then they might come for a high-frequency ultrasound to find those little lymphatic channels next to the veins and figure out what they're going to hook up. I don't see most of the patients that come to them for scintigraphy, because unless they're considering surgery or they're trying to, it's a diagnostically difficult patient, a difficult patient to diagnose. They may say, I don't need any lymphoscintigraphy. I know what's going on with this patient. So they make the decisions as much as anybody. Did you want to say something, Dhruv?
Mickey, thanks for the question. And Brett, jump in if you, or Betsy, if you have a different thought. So if they don't have lymphedema, they're not going to go through this protocol. In general, our patients who come in with lymphedema, they're going through all of this. They're getting an ICG, they're getting MRI, lymphoscintigraphy, and then we're putting all the data together. Now we have another patient population that's growing, that's our early lymphedema patients, are a few failures out of the prevention program or surveillance program. Now those patients, when we're detecting, okay, the LDEX is going up a little bit, we will not put them through all of this. We know they don't have fat dominant disease at this point. We will likely do an ICG plus minus a high frequency ultrasound just to better gauge, okay, what's going on with their superficial lymphatic system, and do we have a potential target for surgery? Thanks.
I'm not sure if this is an imaging question or a surgical question or a little bit of both, but I'm wondering how much the imaging informs how many and where you do lymphovenous anastomosis areas. I know some surgeons down in Florida, Dr. Granzo, for instance, does a whole bunch, and some do a little, and how much does that imaging play a role?
I'm going to let Dhruv.
Yeah, so this is a very controversial topic. So I'm currently running the American Society of Lymphatic Surgery, and this is my second year running it. And in the first year, I basically brought up everyone who does LV bypass, who's does the most in the country, and they each had different answers to that question, and they had different rationales for it, and it pretty much tells you we don't know. Okay. Our approach, and we really, for those patients who come through our program and for those who come to visit and see how we run our program, we root what we do in objectivity. So the high frequency ultrasound has really opened up a lot of doors for us in terms of being very clear on, targets. You saw the pictures Kevin showed earlier. I mean, they're targets. You can see the lymphatic, you can see the vein, albeit small. But this is what we do. We can go in, we can track down a 0.4 millimeter vessel, and sew them together. So for us, in our center, we need to see channels on ICG, so straight line channels, and we then need the high frequency ultrasound to confirm a good vein nearby. And now we have a very objective target. We generally will avoid general explorations of areas, hoping we're going to find something.
Any other questions? All right. Well, thank you very much. And Kathy can get the contact with me if you guys do come up with anything after the talk. Thanks.